Good afternoon. Welcome. Hopefully you're in the right session, PD04, Rethinking Nursing, New Roles and Competency Models, Leading the Way toward a New Standard, Global Standard in Nursing. I'm Dr. Rebecca Greystone. I'm very honored to be here in Berlin with all of you and just this fabulous panel that I will introduce. And in fact, I should not stand in front of them. Let me do this a little bit better. With me today is a very esteemed panel of experts across the healthcare sectors, leaders from around the world, and you will be really delighted to hear what they have to say, their perspectives on this very important topic. Really what we're here to talk about today is sharing a global, unified framework for excellence in nursing. How do we achieve that? And you're going to hear some examples from the panel today. Of course, our bios are in the program, but I would like to introduce each of them before we begin this morning, or this afternoon. I'll start with myself. I work for the American Nurses Association, so I have come this morning from America and had a wonderful trip over. Thank you very much. We have evidence-based models in the United States that really help organize and provide frameworks for excellence in nursing. It's taken decades for us to get there, but really, really important content and important frameworks that we believe, and the evidence suggests, provide real structures and outcomes to improve patient care, certainly through the work of nursing. So we're really delighted to be with you. We know workforce shortages are a major issue around the world. So some of the work that you will hear today, some of the examples we think are real solutions in the workforce shortage space. So let me introduce the panelists. And the program today, we will be going through each panelist. They will have a brief introduction of their topic, their work. I will act as moderator. We do have questions and answers scheduled toward the end of our presentation, so we will have time for that. So please hold your questions. Make a note, if you can, in your program, and we'll make sure that we get your questions answered this afternoon. So again, delighted to see you, and thank you for coming. So let me introduce Dr. Amelia. If you could help me with your last name. Tuipulotu. Thank you. I just asked her and I already messed it up. Dr. Amelia is the Chief Nursing Officer for the World Health Organization. Next is Dr. Wintao Zhou. She is the Director of Education at the National University of Singapore, the Alice Lee Center for Nursing Studies. So we're again delighted to have her as well. Carla Eisel is next. Carla is the Chief Human Resources and Chief Nursing Officer at the Charité here in Berlin. Helena Maurer is to her left as well. Nursing Director and Head of Corporate Nursing and Strategy at Sana Kliniken in Ulm, Germany. Carlson is to the left of her. Clara is the Head of Learning and Development at the Karolinska Institute, University Hospital in Stockholm, Sweden. I understand the Charité and Karolinska have a little rivalry, yes? Well, we'll save that for later, I suppose. And then Dr. Janus Svitsum. Can you give us your title, Janus?
Pardon me?
Your title.
I am Head of Integrated Health Solutions with Medtronic.
With Medtronic, fabulous, yes. We want to thank collectively, the panel would like to thank all the organizers of this World Health Summit. We are delighted to be here. And of course, our session's host, the Charité University here in Berlin, M8 Alliance, and of course, Medtronic, so delighted. Before we start with the panelists, I just would like to make a few words around really the importance of this session. We believe that the time to act is now. For nurses around the world who are positioned to drive new and innovative care delivery models, you may know this, but nurses make up the largest sector of healthcare providers in the world. But yet we are facing a critical and crippling shortage Further accelerated, of course, by something that happened over the last 3 years, we all know, a global pandemic. But the shortage was actually already starting and has been in place for many decades. We believe we cannot address the healthcare workforce, particularly the nursing workforce issues, without fundamentally examining nursing education, regulation, skill, and competency acquisition. The work of the nurse environment, where nurses and healthcare providers practice, and how the interprofessional team, because we all work together, right, to keep the patient at the center of our care, how all of us work in concert to make sure the patient's needs are met. The work environment is a critical partner to the work that we do in designing solutions and aligning those for the future. And lastly, nursing is a social justice profession. We have a moral and ethical responsibility and a contract with society to care for the most vulnerable. This contract, we believe, crosses geographic, political, and socioeconomic boundaries. As nurses, it's just what we do and who we are. So to begin our discussion today, Dr. Amelia has a wonderful presentation from the real global perspective through the World Health Organization. So Dr. Amelia, please begin if you would like to go to the podium.
Okay, thank you.
And,
Guten Tag. A very good afternoon. I am delighted to be here in the beautiful city of Berlin. And of course, very honored to participate in the World Health Summit and to speak on rethinking nursing, new roles, model of care, leading the way towards global nursing standard. It's such a privilege for me. And of course, I hope that our conversation will continue the dialogue towards science, innovation, and policies, and promote health everywhere, keep the world safe, and serve the vulnerable population. First of all, I would like to share the global strategic directions for nursing and midwifery 2021-2025, which has 4 key policy focus on education, jobs, leadership, and service delivery. Education on quality faculty to deliver quality education that is competency-based and is responsive to the population health needs within the context. And that is very important as we rethink nursing moving forward. And of course, ensuring the entry levels to the programs, but of course, the appropriate program, certificate, bachelor, master's, and so forth programs for nursing and midwifery. And evidence have shown that a bachelor degree program is very important for building nurses and midwives' capabilities to contribute to safe and quality care and patient outcomes. Jobs is around ensuring that there is adequate jobs within the health system to be able to provide care for the population, and ensuring that these jobs are attractive for nurses and midwives to stay for the long lengths within the health system. that we are able to recruit and retain nurses and midwives. And of course, the need for investment in the areas of jobs to respond to population health needs. I will go to service delivery before I come back to leadership. Service delivery, very, very important, the regulatory aspect of service delivery, but ensuring that the workplace is supportive and enabling nurses and midwives to be able to deliver care for the population and maximizing the nurses' current knowledge, skills, and competencies to deliver universal health coverage. Leadership is an aspect that I always believe very important to move and speed the development of the profession moving ahead. And of course, as we rethink new roles, competency models, and global standards, that there is established government chief nurses and senior nursing and midwifery roles within health systems. And how I have seen in the past the need that senior leadership positions are within the diverse areas within the healthcare systems in order to better support the healthcare system in its delivery of universal health coverage. And of course, investing in leadership skills and training are so important. Leadership, very important, because the climate, economic climate, will continue and persist into the future. In low middle income country, the challenges are huge. And with strong leadership that is able to work robustly together with finance and political will and key other stakeholders, things can still be done within the context. The World Health Assembly resolution of 2021 adopted this resolution for strengthening nursing and midwifery with investments in education, jobs, leadership, and service delivery. The 194 member states of the World Health Organization adopted this resolution. And we are very glad that the member states have come together, set the rightful foundation, and call on member states to invest in all the 4 priority areas that I have spoken about. And of course, this call for member states to implement policies, those policy priorities, to invest in nursing and midwifery, to maximize the potentials and contributions, skills, knowledge of nurses and midwives within the health system, and that nurses and midwives must be supported, protected, and motivated, and there should be establishment of systems at national, subnational for senior leadership roles in both education and practice. I would like to share from the context my previous experience from Tonga. And I want to say that Tonga has had a very good treaty of friendship with Germany since 1876, over a century, that was renewed again in 1976. So from the Tongan perspective, we developed, and I want to acknowledge the leadership of the nurses in Tonga in our development of national nursing strategies that looks into governance, professional standards, ensuring a career pathway that is favorable for nurses and midwives to rise within the health system. Models of care, quality improvement, practice competencies. Nurses Grow Your Wellness was something that we were calling us nurses together to model wellness, continuous professional development, leadership and management, continuous professional development. We were very tight look at performance management system and education vision. And you can see beside it is the achievement that we made during the COVID-19 of a law entitled Nurse Practitioners and Midwives Act 2021. This is the rethinking. This is the acknowledgement of roles, advanced practice roles of nurses and midwives in the Kingdom of Tonga. And these are some of the documents that we developed in Tonga. But I want to speak to the nursing degree feasibility study that we did in two parts, where we did a gap analysis, and then proposed a business case for the future education for nursing degree and education standards enhancements. We are very glad that the DG of the WHO, Dr. Tedros Ghebreyesus, call and advocate that we must care for nurses and midwives. We must make sure that they have decent pay and working conditions. They must work to the full scope of their practice. And more nurses in senior health positions who have deep knowledge of the context of practice at subnational, rural, and remote contexts, and better contribute at the policy table to policy and, of course, resource allocation to ensure universal health coverage. And of course, this is a call. Please join our global community of practice and our emergency care campaign aimed to save lives as emergencies occurring everywhere around the world. Ich tengi ignen os tiefstem Hessen. I thank you, Malo Abito.
Thank you. Thank you, Dr. Amelia. I think I love her ability to talk at the highest levels of world strategy and governance in the WHO, and be able to then take it down to her own country, her own context, the Kingdom of Tonga. So congratulations, incredible work there. You are really leading the way. Okay, next we have Dr. Wintao Zhou, and she's going to be a wonderful transition into something Dr. Amelia mentioned, which is the focus on degrees and education and the importance of that. And Dr. Zhou is in academia, as you heard in her introduction. So she is going to talk a little bit about that. So please welcome her to the podium.
Thanks, Dr. Amelia, for sharing the global strategy direction for nursing and midwifery. Thanks, Rebecca, for your candid introduction. Good afternoon, healthcare leaders. It is my great honor to be here and to humbly share with you some of my thoughts on rethinking nursing. Today, I would like to take you through the concept of nursing, the challenges which the global nurses are facing now, the possibilities for supporting nursing, and the urgency for global collaboration to develop sustainable nursing workforce. So let us begin. Nurses are the backbone of healthcare, and they play a critical role in the healthcare system across various health settings. Nursing is a profession with a very rich history that has come a long way and continue to adapt to the fast changes in the healthcare setting. Many nursing theories, I think you can see here, were developed to define nursing, guide nursing practice and education, as well as inform nursing research. So here are some of nursing theories that we need to revisit. For the first one, theory of human caring, emphasize the holistic nursing care. Health promotion model emphasize nurses taking an active role in maintaining and improving one's health. And self-care deficit theory emphasize that nurses identify one's self-care deficits and provide care intervention based on the patient's needs. Interprofessional relations theory emphasize the therapeutic relation and communication between nurses and patient. Systems model emphasize the nurses helping patients adopt maintaining their wellness in the face of stressors. Cultures care theory emphasize nurses providing culture competent and sensitive care. Last, Florence Nightingale environmental theory emphasize nurses maintaining a good environment to promote healing. With all this, you must already realize nursing is a complex care phenomenon. Nursing focuses on caring for the individual, interpersonal relationship, system, culture, and environment. By understanding what nurses entails and the fast-evolving complex healthcare, the need for dynamic nursing workforce becomes so evident. However, there are many challenges faced by nursing. They can be categorized into 5 areas. Care complexity, caused by increased diversified patient population due to migration, and complex medical conditions and interventions. Ethical dilemma are increasingly due to increased healthcare disparity and increased global poverty. Shortage of nurses and high work demand and complexity of interdisciplinary collaboration place huge communication difficulties and issues related to patient safety. In addition, rapid technology advancement and increased public health emergencies and natural disasters, which led the nursing practice regulation become even more complex. Finally, fast-changing medicine and nursing knowledge, together with rapid interprofessional skills transfer, nursing education must evolving fast to meet the training demand. It's very challenging. All these challenges directly or indirectly affecting nurses' well-being. Nurses must be capable of navigating all these challenges and continue learning to thrive while maintaining competency and deliver safe care. So as we all know, health ecosystem need a stable nursing workforce to deliver safe and quality care, ensure effective communication, and produce good healthcare outcome. So investment in nursing is very important. Such investment should be focused on support healthy individual nurses, support them through their physical and mentally well-being, maintaining their clinical and social competency, let the nurses receive the respect they deserve and hear their voices. At the same time, develop nursing leaders' competency to create healthy organization culture is equally important. Leaders should aim to narrow the organization hierarchy, support nurses' professional development, recognize and reward nurses' achievements, invite nurses to provide input on policies and organization culture. Also respect the diverse nurses' perspective. In Singapore, the government and healthcare leaders have realized the nursing complexity, and many strategies have been implemented to strengthening the nursing workforce. Here are some examples. Engage technology telemonitoring, and AI-driven reporting system to reduce unnecessary administrative and documentation burdens for nurses. Adopt evidence-based computer decision-making algorithm to guide care decision-making and facilitate the communication between multi-professionals. Redesign care models with assistance of the technology to empower nursing profession, enabling them to lead in interprofessional care in specialties, transitional care, community chronic disease management, and populational health. Enhancing continuing nursing education and developing training by developing multiple competency frameworks to ensure nurses remain competency and up to date. Promote nurses' well-being by implementing flexible working hours, providing career coaching, and offer resilience support. Last, review the nursing remuneration package and retention bonus is a strategy indeed implemented by our government. So with all this, we all know nursing is going to face even more unpredictable challenges moving forward. Rethinking nursing is really need to have global nurses collaboration to generate culture-sensitive evidence, nursing practice, assessing nursing migrations and workforce mobilities to mitigate inequity and care disparity. Ensure global studies to address significant nursing challenges and well-being. Advocate for policy that enhance the complexities of nursing. Leverage technology to reduce nurses' workload to prevent burnout and promote well-being. Last, establish global nursing education alliance to support the education of the next generation of nurses. At the end of my presentation, I hope to say, rethinking nursing is a collective way effort to ensure nurses' well-being. Thank you.
Great. Thank you, Dr. Joe. That was an entire semester of nursing theory in about 2 minutes. So well done, well spoken. And I think it speaks to the importance of and the fundamental nature of having a common platform from which all nurses are educated in the sciences and the arts of nursing, and also how those translate into demonstrating competency. That's a really important part. And in the United States, it's something we are really moving into, competency-based education versus time-based education, where you sit in a seat and you hear some professional development, and then now you're competent to perform those skills or activities. It's much more about demonstrating the ability and the competence to do so. So I think that's a great opportunity to bring those and many of your other remarks forward. So lots there as well. We're going to transition now into a really nice, interesting part of the panel. And this is a little compare and contrast. So the next three presenters are going to present the context from two countries, our own dear Germany, I'll say my own, dear Germany, and what is happening in Germany and some recommendations. And then Clara will talk from the Swedish perspective, the differences in practice and care and education and many things. So I think the next two groups of panelists, I think you'll find really interesting to see what's possible. And how nursing in Europe in particular and healthcare for the healthcare workforce can address some of those pressing problems. So Carla and Helena, we'll start with you first.
Yeah, thank you very much. We are very happy to be here with you in this afternoon to talk about the very important topic of rethinking nursing. As our pre-speakers already pointed out, nursing is a crucial part of every healthcare system. And as we live in unstable times, we think that a very good functioning healthcare system is the cornerstone to political stability and trust in the politicians who act. Therefore, we think it's even more important to rethink nursing, to save and secure the basis of the healthcare system for the future. Therefore, Helena and I have the honor to tell you some facts, issues, and maybe some solutions for the German healthcare system. And we are super honored that we have the trust and confidence of Minister Lauterbach, who gave us his statement that he also thinks that rethinking nursing in a way that's competency-based and involves the nurses on an autonomous level in the healthcare system.
Thank you, Carla. I'm proud too to be here. Yesterday I was in Chicago on the biggest nursing conference, and I saw nurses connect together. Nurses have network. Nurses want to work together and to think together to build their excellence. But now we come back to Germany. I have no jet lag. I'm here because I have many spirit take away from Chicago with over 15,000 nurses. And now we are back in Germany. We take much things with us here to Germany, but now we want to talk about facts. In Germany now it's so, we have more than 35,000 nurses are missing in the hospitals to keep a current medical standard. 7% of people started their vocal training in nursing, and 30% of this. It's less in the last years. More leaves the job at the education because it's not a good environment in the hospital, and they leave. We must do something about this. And we have less academic degrees in the hospital. We have 1.74% because it's slowly grow. 5 years ago, we have 0.5%. It slowly grow, but it's some hospitals have 0%, some hospitals have 5%. We have a very slow academic degrees in the hospital. And we have a problem with digitalization. We have big projects with digitalization, but now we have 83% of the hospital have low, medium degree of the digitalization. And we have a German aging population. We like the aging population, but there are many needs of healthcare and of nursing, we think.
So if you listen to these facts, 1.74% of the nurses in Germany are academically trained. And we heard from all the speakers that bachelors, Dr. Melia pointed it out very intensely, are very important to speed up the keeping and the hiring of nurses. So we are kind of a first world country struggling to serve and offer attractive conditions for nurses. Our vocational training, which is quite good, but it doesn't reflect the necessities we have in the system for nurses. Bachelor's and master's degrees are not attractive for people in Germany because if you attend a bachelor's study, you don't get any interesting job in the end in the clinical support. You only can go into management jobs, but not in the clinic. That's where we struggle. That's why we can't attend people to enter these jobs. Nurses in Germany, for example, are not allowed to diagnose. They are not allowed to prescribe medication. And they're not allowed, just as an example, to vaccinate by themselves. They always need the supervision of a medical person. That's why it's not very interesting and attractive to do a bachelor's or master's degree, and that's why we stick with the 1.74% of academically trained nurses in Germany. Advanced positions like advanced nursing professional people are not common in Germany because they are not allowed by the law. The framework for nurses is very strict and kind of narrow, and therefore we lack positions that are attractive in the US or in other countries.
Yes, the futures of challenge. We have many challenges of nursing, but we have solution afterwards with us. Imagine we do not find solution for the workforce of shortage in nursing, we get a big problem. I want to tell you about workload on existing workforce increases, then job exodus increases, resources for emergency care will be limited, patients will have a long waiting times for surgeries and treatments, quality care sinks. Quality of life of an aging society declines. Entire facilities need to be closed. We close some facilities in Germany, but we want not closing facility if we have no nurses. We need nurses for the closing hospital. We need nurses too for the healthcare system, about healthcare nurses and so on. Entire cost rise to rising cost for hiring cost. And technology needs to fill the gaps, but we need nurses to work with the technologies and integrate and implement technologies in the hospital. And social trust in politics declines. When we have no nurses, I want to show this cartoon. You know, sometimes somebody knows this cartoon. The patient asks, "You don't look so good. Should I call the nurse?" And in the bed behind, she said, "I am the nurse." Yes.
So we heard a lot about problems, and it's always good to come over with some solutions. So we need to imagine that nurses in Germany also have a high level of socio-economic acceptance, as they have a profession which is autonomously and clearly set in the law, so they can, dependent on their level of education, fulfill their jobs. Bachelor's and master's degrees lead to nursing practitioners and advanced nursing practitioner roles, competencies, and, we heard it before, adequate salaries in this field.
Yes, we have a sectoral difference, and we must reflect it is in a legal framework and job description. Clinical practitioners and advanced clinical practitioners, a master degree and bachelor degree, clinical nurses in focal training and specialization, elderly care nurses, community health nurses, and the international workforce gets easily integrated when we have academic nurses in bachelor and master degree. And digitalization fills the gaps and makes the job attractive. We need digitalization and a high competence in nursing in master degrees and bachelor degrees and doctors in nursing.
So imagine we could have, like we showed here, a framework for nurses in Germany, how they can work in hospitals, and we hope that the current legal approaches will change the system and give us some opportunities. If we have a relevant qualification mix in the system which is financed, then we get the attractiveness we need. And therefore, as Rebecca pointed out, the time for action is now, and we see the opportunity that current legislative initiatives like the hospital transparency law, the hospital reform law, give the opportunity to change the situation for the nurses, make the basis for the future, and give us the opportunity to change the requirements for the future hospitals, for academic education boosts, and we have this already in Germany for the midwives, so we think the possibilities and the frameworks are already set. We think securing this future workforce by boosting nurses' education and their legal framework will be a good point to give back hope and security in the healthcare system. Thank you very much.
Wonderful. Thank you. I think that was a really honest and candid perspective of what is happening in the German healthcare system, but I love that you attach solutions to that, and the solutions were very broad and applicable to the list of many opportunities that you also presented. So I think that gives us all, including where I live, lots of opportunities, because certainly America has a lot to learn from our European colleagues. So thank you both. That was exceptional, and I hope you all are taking notes for some of these solutions in the audience. Wonderful. Now we're going to switch gears a little bit to have another country perspective that I think you're going to be as equally enthused to hear. Clara is going to, from Karolinska, is going to talk about what is going on in Sweden.
Thank you so much for letting me come today. I'm also very honored to be with colleagues from all over the world. I'm going to give you a little background on what and how we have done things in Sweden, and particularly at the Karolinska University Hospital, because we see the same challenges that you see. So Sweden is a small country. We're only 10 million people up in the far north of Europe. And we have a history of having big trust in our government institutions. We have flat organizations, and we always had mandate close to the employee across the country. We have a healthcare system with high level of academia across all professions, and for about 35 years, the nursing degree is a bachelor degree of science. Before that, it was a 2-year university degree. And we have a history of invention and sharing knowledge across the world. And hopefully I can do the same today. So the history of Karolinska, or the journey that we have done in the past 5 years, is that, in 2019, pre-pandemic, we had more managers than beds. We had 960 managers and 940 beds. And this was the end result of a reorganization that we did. We were only doing 88% of the commissioned care. And we were a deficit of 2.4 billion crowns. We were an organization divided into silos, so we weren't cooperating very well. And we only had physicians in high-level positions. So we only had nurse managers on first-line management. So then we had COVID, and we all had COVID. And so we don't think it was COVID that was the solution to what we did. But during this time, we adjusted the organization. We readjusted it. We started working closer together, and we put nurses in charge. So it's the level up we had nurses and physicians in operational management. So we put nurses in charge of budget, beds, and operations. And because we all know who makes sure that we have a bed, who's staffing the beds. It's our nurses, it's not our physicians, because our physicians, they move across the hospital and caring for the patients when they need their specialty. And throughout this, today, we have 20% more beds than we had 3 years ago, with same staffing numbers. So what is ahead of us? We know that we have raging costs, we have less resources, and we need to keep up with capacity. Because at Karolinska today, we don't talk about the deficit numbers, or we're missing 500 nurses or these many beds. We just say that we will never be as many employees as we are today, and we will have double as more patients in our care. And everything that we do today have to aim to be able to keep up with capacity. So, how does the Swedish legislation support our change? Because we need to do the change in Sweden too, even though that we have nurses in charge and we have bachelor degrees and 25% of our nurses have master's degree. So the legislation, and this is actually from the law book, few rules dictate who is allowed to do what in Swedish healthcare. It is based on the individual's competence. So it's only 5 things that doctors can do that no other profession can do. I'm only talking about nursing and healthcare professionals here. I'm not talking about dentistry and our other professions. And there's only one thing that a nurse do that can be delegated to another healthcare professional. So we are looking at increasing the competence supply by expanding the scope of practice for nursing. And it's funny that I mentioned scope of practice, since I've just said that the scope of practice is huge, depending on your competency. But it's because we also suffer from the cultural impact on the world, that we also have a belief that a nurse can only do this and a doctor can only do that. So for us, it is a cultural journey. But we do need to expand the scope of practice. And we need to create new roles based on the competency levels of the individual to promote task shifting. Because in only 7 years from now on, the Swedish population, and I think it's the same from the whole of the Western world, that the number of people over the age of 80 will have doubled, and we will only be 34% more in the workforce field. And out of those 34%, some will be on sick leave, some will be studying, and some will be on parental leave. So you don't need that many more people. And in Sweden, there's only 134,000 more people. And they also need to be driving buses, join the police force, be teachers. And that is the future, and we can't debate it. So the healthcare in which we are practicing, it was designed over 100 years ago. It's a very long time ago, and a lot of things have happened since then. And it's our responsibility to change it, to transform it. Because it's not the periodic system, it's not set in stone, it's just an organizational model that we can change. And it is really frightening, and when we talk about this in Sweden, it is an uproar. We are protective of what we have, the knowledge we have, our importance in society. But when it comes down to, will we be able to deliver care to the best of our ability, we need to change. So my key insights that I want to share with you is to put nurses in operational management, create new roles based on competence, change and challenge the legislation and utilize the strength of EUHA, our European cooperation, to start there, and then, in a perfect world, that we can align nursing across the world. Thank you.
Wonderful. Clara, thank you so much. Really, I think another great case study in a totally different way that nursing has been educated, having a lot of leadership, which is, I'm sure, a very good strength for the country. At the same time, we know that leaders, in particular middle managers, are struggling probably the most in the post-mid-pandemic times. And that is really the future executive leaders and executives and other leaders in the organization. And they're role models to nurses who are looking to progress and to move up into other roles when they see that their leaders are struggling or not enjoying their work. I remember when I was a new manager, people would say to me, and I would try to mentor them and have them come along, and they would look at the hours and the time that I spent. This is more years ago than I will admit, but they would ask me, well, why would I want to do what you do? Because look at the hours that you work and the time that you spend away from your family and friends. So it is a really important thing to make sure that as we look across all these different examples, we're also considering the different roles within them and how can we be more interprofessional and competence-based, even at the leadership level. I think a really critical part of that. To round out our panel, and before I see all of you are sitting on the edge of your seat waiting to ask questions. So before we do that, we're going to conclude with our last presenter, and he's a physician and brings another perspective. He's told me many times how much he loves nursing and nurses, so I'm delighted to set him up with that comment. But Giannis is going to give us a different way of thinking about a more broad context, which is how we organize healthcare delivery. So not particularly one role, but how do we work within the ecosystem of healthcare to be more efficient and effective. So I'm really excited for you to hear him as our final panelist. Giannis.
Thank you so much. Thanks, Rebecca, and thanks for having me. It's really a privilege speaking to you today. And as Rebecca said, I'm a physician by background. I'm a process and transformation expert, and I was asked to give a little bit of a complementary view on why we need to rethink nursing, and I think it's mandatory. And as Carla said, it's basically we're in an evolution, and we cannot go on with processes that have been established 100 years ago. So imagine you are at a rock concert, and all of a sudden you enjoy everything there. We have a stage like this here, but often they're much higher. They're like 20 feet high. And in the middle of the concert, this singer would just look at the audience, then turn their back, and then jump. And then you would see, some refer to it as crowd surfing or stage diving. But basically, what does it take for somebody to just turn their back and then jump into a crowd and be caught and trust that you will not break your bones or head or everything? And that's exactly what our patients are doing. So they are admitted to our hospital. They have no other choice, right? So the singer could say, well, why are you doing this? But patients have no other choice. So they enter a hospital in full trust that they will leave it with maximum outcomes, maximum safety, and that's what we deserve to optimize. And for God's sake, the singer here didn't have a team in a silo that says, well, sorry, I didn't kind of see him falling, but this is your side of the table. So this is more in sync. Now, what does it have to do with a more complex industry like healthcare? You could say just catching a singer here, it's a very simple manual task, and it's a little long way to go. But here you see another industry which, again, relies on a team that's fully in sync. And I save you from technical issues showing you a video, but if you ever have the time, just Google. You find hundreds of these on YouTube, where a pit stop in a Formula One, there is a car heading into the pit stop, 50 miles per hour, then decelerating to stopping. There's a lollipop guy just, trusting that he's not run over. And then you have 20 people around it, one fueling the tank, fueling the car with 20 liter per second. And this pit stop now takes 5 seconds, or the world record is something below 2 seconds. You have somebody taking off tires, putting in new tires and so forth. And all of this is super safe because we've also seen lots of crashes or the whole thing going up in fire. So there's also people in standby with their extinguishers just watching if something goes wrong. Now, if you look at this today, this is fully in sync and it's kind of it's iconic for good processes and safety and so forth. But if you look at the same process some 30 years earlier, you would see that this would have taken a minute. And there was much more accidents and much, so to speak, poorer outcomes. And now, make no mistake, and we showed these kind of slides in many care settings with mixed teams. The one who's driving the car here, this is our patient. That's the one that deserves the best outcome, and that's the one that has to go through the whole journey. This is not the CEO or the management of the hospital. This is not the doctor. This is just one of the functions here. And you could argue whether the doctor or the nurses is the one that's fueling the gas or kind of replacing the tires, but the patient is the one that we help go through the journey. Now, I just said that this has gone through an evolution over decades now and has been optimized, and it's good opportunity to watch how you can leanify and optimize processes here on the left-hand side. So there was a lot of numbers in here, and I think we've seen it in the slides about care theories, and there was a reference made to Florence Nightingale. Just keep in mind, she was not just a role model for good nursing, she was a statistician. She was looking at what makes us better, what makes us faster, how can patients heal better, which means faster and safer. And so you see that this process is optimized now from 60 seconds to something like 2 or 3 seconds. And the same would go for any situation in our complex process chains from, let's hear an intervention, let's say a complex heart surgery, or if you just take a ward situation. So this relies on people that have clear roles and then operate on top of their competency. So again, there is no one that is kind of, an auxiliary function or supporting another role and say, well, I need to ask this function first. No, it's clear. If you're the guy that is fueling the car, then this is your responsibility, and it's clear, and it's your competence, and you can do that way better than somebody who is specialized in replacing the tires and so forth. Now, what's the reality? If you look at, and this is a random snapshot, you don't have to read all the fine print, it's too small, but if you just look at this bar in the upper half of the slide. You again don't have to look at the numbers, but you see the red time of any given time of that patient. This is representative. Was the time where the patient was sitting somewhere in a hospital, not knowing what's next, and then going to the next part of the hospital that told them, yes, this here is imaging, this is radiology, and sorry, well, they didn't tell you this and didn't tell you that. And then you have some of the green, and luckily also the patient then, eventually got lunch, which was not planned because nobody was responsible for it. But then you have a patient who spent in total maximum 1.5 or 2 hours on a day, and the rest of the day was idle, waiting, and kind of having experienced that, well, if these guys here in this hospital are not very in sync and no one can tell me what's happening next and I can experience stuff go wrong, then maybe this patient would not turn their backs and jump just blindly into the audience next time they experience it. So this is exactly where we see the process in the pit stop, where we have opportunities to optimize. And in terms of numbers, if you look at all excellence programs, take enhanced recovery programs, take magnet programs, you see that lengths of stay can be reduced. Now we're down to 30% less than what we had before such programs. And the same goes for, here we have a day that is usually before surgery, can be done on the same day, and so forth. So at the end of the day, it's time saved for nurses, for doctors, and for patients, but it's also cost for the system. And this can only be done if we use people, as it said here in the yellow sticker, on top of their qualification. So how do you do this? So you see on the left-hand side, this is a mixed team, doctors, nurses, also people from the administration staff, looking at, again, this is, if you will, the pit stop, what's happening next and what are we doing? And then they're discussing. And this is about jobs to be done, who does it, who has the qualification, and then we use people on top of their qualification, and not just because the org chart says, this is my qualification, this is your turf, but and as Carla said, we need to reinvent the system. We need to define what is best for the patient and what is best for the team. So this is something that has been started again, and there were always these waves in healthcare sector to tackle it. Personally, very much a fan of lean, so that I'll give you a lean example here. But it doesn't matter. At the end of the day, it's about professionalization, qualification, standards, and optimizing what we've seen in the Formula One 20 years ago and 30 years ago. You see here a very, very nice example. I think that emphasizes how important it is that this is a team play. Picked the University of Maastricht because I believe they're a real lean hospital. You see on the right-hand side, it's a long journey. Takes a while. But you see that the board, you have a CNO, you have a CMO, you have also a COO and so forth. They're all fully trained in the organizational philosophy that they're using. And then it's rolled out, again, in mixed teams that work together to optimize and rethink the process, rethink the patient experience and outcomes. There is a shared decision-making, all good principles that we now love so much in programs like Magnet. And at the end of the day, they, of course, want to display to the external world and here with a license program and so forth. So with that, thank you so much for your time, and hope that you can buy into my message that we really not just need to rethink nursing, but it's time to do much, 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 much better together.
Excellent. Awesome. Jonas, totally agree. What I love about his solutions, they're always very practical things you can do today in your healthcare organizations to eliminate waste and to really, and that's what your teams are asking for. No matter what their role is in the organization, they don't want to do things that aren't value added to in healthcare, moving patients, keeping our individual workers satisfied and enjoying the work that they're doing while focusing on the patient at the center. And there are many evidence-based, time-tested solutions, as Jonas mentioned, just a couple with Lean, Six Sigma, and some other examples. And he has a long list of different settings and operational efficiencies that I'm sure he'd be happy to talk to you about later on. Now is the time to open up questions, and I again would encourage you to ask questions that you have. This is an unusual opportunity to have representatives in healthcare from around the globe. And yes, sir, and we have microphones, I believe. There's a gentleman right there. Okay, him, and then in the back, and then the lady in the white, please. If you could introduce yourself, please, if you don't mind.
Okay. Well, thank you very much. I'm Ber Omen, European Specialist Nurses Organization, and I'm so hugely proud to be here and to see all these speakers. There's one it's much about politics and changing politics and changing the new environment, and I really think like the word rethinking. And I'd like to come to Amelia, because on the strategies, point number 7, only below, there's influence policy voice. Where, on what point did it come into your strategy? Because there's a lot of elements, but for a lot of organizations going into the political environment, and I'm really pleased to see Milka and also Paul of the European Public Health Alliance also here, because they're really doing very hard on the political voice. So for us as nursing, it's really a hard point to come to the political domain. So, but that's where the question is: at what time did the political moment come into the strategies? Thank you.
Thank you very much for that very important question. I think reflecting back to my work in Tonga throughout my leadership, I realized the importance of having influence on policy and political will of the day in order for resource allocation and to support all the strategies, even though it is number 17, but it was the one that I was robustly working on every day throughout my journey. And when I was Director of Nursing and Government Chief Nurses, so that very important that you have that very close relationship with the politician of the day, the government of the day. Of course, it changes and you will adapt accordingly. But building that political competence to be able to have a debate, a dialogue, and position nursing and midwifery on the table for budget allocation, local budget allocation, and speed up in priorities for donor support is critical in order for something to be done. In Tonga, we have a saying that says, "Lea pe ngā ue," which means if I have pretty strategies and it's never implemented, people, don't really see you as a leader. People will respect and population will trust you if you deliver on those strategies. And of course, it's always tough, but I think rethinking and transforming the system, we cannot survive if we continue to be in the space of yesterday. We have to be, our hands must be on the deck, and we must be robustly involved in that. There are some challenges, but we must face on those challenges heads on with the political environment. And it can be done. There is no doubt.
Great, well spoken. And I think she said a key thing. You have to be at the table. That's step one. You can have all the relationships, but if you're not there in the meetings, in the dialogues, having those relationships that makes those types of changes much more difficult. I'm going to go to the gentleman in the back, right there with the gray jacket. Yes, please. And then, ma'am, you with the white jacket after him, please. Thank you.
Thank you so much for this wonderful and important discussion and presentations.
And I'm sorry, can you speak a little louder because it's a little difficult for us to hear.
Is it better now?
Yes, thank you.
Okay. So once again, thank you so much for this wonderful and insightful presentations and discussion. I am Luca Dellak, and I'm here on behalf of the European Medical Students Association. So in light of the persistent healthcare workforce crisis and the pivotal role that nurses do play in healthcare delivery, it was task shifting that emerged as a pragmatic strategy to try and optimize the available workforce in various contexts. And I think you, Ms. Carlson, briefly touched on it. And nurses are often those who find themselves at the forefront of this strategy, absorbing the additional responsibilities to bridge the gaps in service provision. So consequently, I would like to ask, how can we ensure that task shifting and especially delegating certain responsibilities to nursing staff does not on one side compromise the quality of patient care and overburden nurses, while also on the other side support the well-being and professional development of nurses globally? It is directed to anyone on the panel who feels most comfortable answering. Thank you so much.
Thank you. Thank you for that question. That is I've been a nurse 30 years. That question has been prior to my practice, and I think will continue, is nurses do end up picking up in a service organization kind of all the loose ends, and our roles often get diluted because we feel that obligation, moral and ethical obligation. Would anyone like to address that in your own context as far as what strategies have been put in place to try to help nursing stay within the nursing realm? Or is that something that still remains a challenge, that ancillary care, allied health professionals have a role as well? Carla, please.
I can try. I think the thing is most of all an HR thing. We have to implement roles and competency models in the clinics, and we have to make sure they are being lived. And that's a huge challenge because we are not talking about a process of producing something, but we are talking about people. So there are situations when you have to leave your role and step into another part or in another turf, how Yannis pronounced it. But you have to go back and fulfill your job and hand over. And I think the defractioning of the system with all these different approaches made it very complicated to implement a teamwork, like a team that provides care no matter what role someone has. And that's what Yannis pointed out. We have to put the patient in the center. And if we do that, all the roles group around. So I like the picture very much. And I think we have to rethink the hierarchical system of hospitals especially. And if we succeed with this, we form teams and we form a communal spirit that's centered on the patient. And if we succeed with that, I think your question will be answered.
Clara, I think you gave a great example when COVID hit. The team rallied and 20% more capacity. That doesn't come out of nowhere, right? That is a very intentional use of, and people have rule clarity and they know exactly what they do because the patient's in the driver's seat, in the middle of that car.
Yeah, that's true. And what I didn't mention in my presentation was that in Stockholm, the region of Stockholm, over the past 7 years, we worked on competency, strategy, and levels for all health staff that defines scope of practice within each step of the competency level. And when it comes to task shifting, I think it's very easy. Like if 150 years ago, 200 years ago, when we started to have healthcare facilities, there were only really one role, it was doctors, and then there were assistants, and then the assistants grow into the nursing profession. So it's a bit of a classic example of where one profession then just picks up tasks, and then they've been clustered for a profession. And so what we've done, or looking into, is what tasks can we give to another profession. And like Yannis was talking about, we don't have the same patients as we had 200 years ago. And what does the patient need? And we have AI and we have brilliant medical wonders today, and a much longer life expectancy. So we have to regroup and challenge the legislation to come with that, to grow with the organization.
And just wanted to add, how I interpret your question was what is in and what is out of the scope of nurses, and how do we make sure that we continuously kind of revisit. And again, this is a little bit the data view, but now we have data, it's the outcomes, right? If a group, so here you would see, if you think back of that picture where people discuss who does it best, then you would ask, do you have the competence in training and so forth? But everyone could say, yes, I have. But then you would say, well, show me the data and show me your process. And this is where we are today. And this is in all the programs that we have, that we continuously involve. And there will be tasks which are today in role 1 and will move to role 2 because, as Karin said, it's evolving.
It is, yeah. You don't know what you don't know, right, unless you do some measures. Yes. If somebody could hand her a microphone, the lady with, can you put your hand up again, please, if you don't mind? Oh, and Alex, if you don't mind, there's a couple other people ahead of you, if you don't mind. I'm sorry. Several people. Go ahead, please.
Hello,
Sorry.
I'm Anja Schönmüller. I'm a youth delegate from Germany and a student in medicine and political science, and also a former nursing student. So actually I'm one of the ones who ran away from nursing since I saw more opportunities in medicine. But I would like to talk about another thing, because I think one of the huge problems in rethinking nursing on the level of global health hasn't been addressed, and that's the global migration from the global south to the global north of nurses. And I would like to ask about that. Are there some policies planned on a global level promoting a more just global division of nurses without a brain drain from the global south to the global north? I know there's the WHO conduct code of practice of 2010, but are there measures planned beyond that?
Would you mind taking that? I'm looking to Dr. Amelia. She probably has more expertise in global migration and positions on that. Would you mind answering?
Thank you very much, and I just want to acknowledge that here we also have the regional policy advisor for nursing and midwifery, Maggie Laggins, who is doing great work within the European region with me here. So I'm hoping that towards the future you will robustly work in collaboration with her and her leadership within the region. That is a very important area with regards to migration of nurses and midwives and health care workers right now, which creates significant shortages of nurses and midwives, mostly in low and middle income countries. As they move to more favorable green pastures. WHO advocate has a code for mobility of healthcare professionals, but advocates for ethical international recruitment of nurses and midwives and healthcare workers, yet as an advocacy for member states, and member states within their own jurisdiction to lead the implementation of that code. So WHO's position is always to safeguard healthcare professionals and countries, host countries where these nurses and midwives and healthcare professionals move from. But of course, that is to be implemented by the member states within their own sovereignty. So, so that is, WHO has always given that advocacy for ethical international recruitment of healthcare professionals. Yeah, so I think that is the position that I would like to share.
Challenge. Very good challenge. Thank you for the question. That's excellent. There were a few people over here, a lot of you actually. So how about this gentleman right here in the blue? I apologize if I'm not getting them all in order. Sir, if you can hand him the microphone. This gentleman here. Oh, would you like to say something as well? Please. And then you're next.
Hi. So I'm Maggie Langans. I'm the Nursing and Midwifery Policy Advisor, Amelia's counterpart for the European region, which reaches, you know, it includes the EU, but it also includes as far east as Mongolia and China, so the Central Asian countries, the ex-Soviet Union. What I'd like to add to this conversation and sort of answering that question about mobility, I think the issue is that the global strategic directions on nursing and midwifery are trying to encourage that bundled approach, that we're looking at education, leadership, service delivery, and jobs all in one. The reason people are moving is because their conditions are so bad, or recipient countries are attracting them because they've cut on education for nursing or bursaries for nursing, or they have cut supports for the nurses in their countries that would keep them. So the first thing is really to reemphasize how important that tool is and that it is a bundled approach. I'd also like to speak to leadership, because I absolutely agree that the management leadership competencies for nurses is really important. But what we know is that the State of the World's Nursing report showed that government chief nursing officers are linked to better regulation of education and working conditions. When I came to post, I called for nominations from governments. Unfortunately, I did not get one from Germany, but I have one from Sweden, I have one from 37 countries. We meet every 2 months, and these government chief nursing officers are often, and in Sweden the case is that they are overseeing a patient safety portfolio as well as the nursing conditions and the nursing education regulations, and it automatically sort of links that nursing work to patient safety, which speaks to I really liked your presentation, Dr. Zhu, because it really emphasizes, and here I have a challenge to this panel, that it's not really about rethinking nursing, but it's about accentuating the value of nursing as being so complex, as being one that for centuries has managed resources. Nursing, Florence Nightingale didn't just introduce infection control. She managed the resources in that setting so that they were better used. And we see time and time again nurses faced with this responsibility at the floor, and it's just not recognized. So government chief nursing officers are really linked to that. And just a last point about the government chief nursing officers, we're working with Sweden, Ireland, Israel, probably less so now with Israel, but and the UK's government chief nurses to support the Ukrainian refugees that have left who are nurses and do want to continue working as nurses abroad, but linking them with the Ukrainian government chief nurse to make sure that what their skills, how we develop their skills abroad will be aligned to what Ukraine needs. So it's working in mental health rehabilitation nursing scopes.
Great.
So again, an example of the effect of that.
Perfect. Thank you so much, Maggie. What a great addition. And you have a ringer in the audience. That's wonderful. Yes, thank you. We just have probably time for maybe two or three more questions. So please, sir, go ahead.
Thank you. My name is Stefan Wisbauer. I work with Lecturio. We work in nursing and in doctor education. And first thing I will say, I was at the Professor Wetau, pleasure to see you. We worked together at NUS. And first thing I want to mention, I was at the Consortiums of University of Global Health Conference, and one of the discussion points there was a statement which simply said, "Where are the nurses?" You know, so I'm very pleased to see such a eminent nursing panel here, and I just want to encourage you all to take a stronger, be more present in some of these global conferences, because you are so important, right? So why are there not more panels like this one, at all of these big conferences? So I just want to applaud you for being here and want to encourage you to be much more present elsewhere as well. I also have to say, working with doctors and nurses, the nurses I've worked with and dealt with have always been more consistently wonderful than the doctors I've worked with. So I think you make a wonderful profession to work with. My question is to this point on changing the scope of practice, and especially in Germany. And I'm just curious to hear, what are the practical obstacles? We have a doctor on this panel. He's the sole male on the panel. That's not a criticism. But I'm just wondering if the doctor profession is actually an obstacle for you in getting these things changed, or whether you're getting support from the doctor profession in getting these changes underway, or whether it's more the politicians, who also tend to have an overweight proportion of males in it, that are the problems. And what is your perceived probability of actually making meaningful progress in the next year or two? Thank you.
I think, Carla, that squarely was to you as the start.
I think it's more history than a profession that's an obstacle, because in Germany's history, it's, as Clara said, somewhere it's different, but the outcome is the same. Like in Germany, a vocational training was very common for nurses. Only in the eastern part of Germany it was a bachelor's degree, but not in the western part. So we are kind of used to nurses as support people in the system, and the development that took place around Germany that gave a broader scope of practice to nurses stopped at the borders. And we have migration as a booster, I would say, because people that migrate to Germany from other countries, and we have a lot who come, they are disappointed with their scope of practice because they're not used to just support but act by themselves and have their own scope of practice. And that's a big booster to change. And I think that most of all professions in the healthcare system see the evidence that we need academically scoped nurses with their own scope of practice. And I see a big support in all professions. So I think, and that's why we say it's time to act now. We have some changes in the legislation because the healthcare system is sick, so we need to change something. And that's why we think that we can see changes now, and we have to talk to politicians about it.
Janis, please.
Just wanted to point to Helene Maucher, because just as a reference, 2 weeks ago we saw the Nursing Management Congress in Ulm, and she's representing Asana Group, which is with 70 hospitals, one of the large really providers, and you had the CEO, Dr. Schick, and you had the CMO, Dr. von Kossel, they're giving presentations about the importance of interdisciplinary pathway work. So I think this is something that may not have happened 20 years ago, but I think there is a large change in the culture, also in the physician side. Maybe it's different across the players, right? You have the old-fashioned, we heard about 400-year-old organizations, and you have more, but I think we're clearly all, it's a must, because we cannot afford, as Carla Eisel just said, the system is sick and we all need to act.
I think physicians want academic nurses to work together on eye level because patient-centered care, we speak about this, patient and family center, and the physician have the same goal to the best for the patient, and the nurse is the same. And they work together, and it's not much physicians who said, I'm the physician, I'm on a very important person in the hospital. They want to work together to have a good environment. The chief physician wants the assistants learn with the nurses together. We have education areas in Ulm in our hospitals, and there learn the physician and the nurses together, and think this is a good thing to learn to prepare the nurses to get higher degrees.
My takeaway is it's happening. It's happening in Germany now, but you can see really persistent, strong leaders.
Excellent.
I'm getting the high sign that we are going to be have to leave this room in a few minutes. I'm just going to take a random person. This lady right here, I'm sorry, with the mask. Would you mind? And I don't know, are we allowed to stay afterward for a few minutes? I'm not sure if we're allowed out of this room or not, but if we can, we will stay for a minute to answer any other questions.
So my name is Sarah Rotenberg, and I'm a fellow of the Missing Billion Initiative. We know that 1.3 billion people around the world have disabilities in some form, and because of various health inequities, have a 10 to 20 year difference in life expectancy. And health workers often report not knowing how to adequately support people with disabilities. So to help close this gap, how do you think nursing education should address the skill gap and improve competency to help people with disabilities access better health care? Thank you.
Interesting question.
Yeah.
Dr. Joe.
Thanks. I think everybody looking at me. Thanks for the question. I think that's very important. Personally, I think in Singapore, we are also not doing so well for that. What we are going to be moving forward is to engage patients to work together with us to develop curriculum. Because sometimes, if we develop curriculum from the healthcare per se, we were missing some portion. But invite the patient on board. That gives us a holistic picture. I do not know, we are still in the process to develop for that. I hope that can be a strategy for it. Thanks. Thanks for the question.
Great, well said. The involvement of patients is critical, and no matter what our specialties are, to hear from them versus taking decisions on their behalf. We have 1 minute, and I'm going to wrap up with the closing. I think this has been incredible. What an amazing panel of experts to talk about the call to action, which we think is particularly imperative now for the future of our healthcare system. Healthcare is in crisis. Our healthcare workforce is in crisis. The systems of care are in crisis. And you've heard that, and you've probably experienced that within your own context. And really, if you think about other industries outside of healthcare, there are very few health industries in the world that don't consider healthcare a basic right. But there are many differences in the pathways to get equitable access to care, depending, again, mostly on where you are in the world and the socioeconomics of your own situation. Available services that we have continue to be stretched, really almost, if not at the breaking point in our current healthcare systems. And this is position or profession agnostic. You hear about the well-being of all providers, nurses, care providers, respiratory therapists, etc., social workers, everyone that is in the ecosystem of healthcare. I think it's really important to remember that. I think we must be willing, as you've heard the panelists mention today, in several solutions, we have a call to action around education. We have a call to action around politicians and the decision makers, whatever context. Make sure that they understand what is happening. Telling stories, personalizing these experiences are critical, because you, me, your children, my children, our grandparents are all in the same, all recipients of care. And if the right people aren't in the room, in quotes, the arena, the space, for them to access care and access it in a way that really provides equitable opportunities for individuals, I think is really, really important. And I think I just want to add this, what Carla and Helena said, which is examining cross-country portability for practice and providing safe care and competency-based models, as you've already heard mentioned several times today, to really give nurses the position, the value that nurses bring to the table, I think has long been underestimated for a lot of reasons. But that's why we are here. This is why I think this is the first time nursing has been invited to this panel, is to really bring forward the voice of nursing, which is so critical in healthcare today. I think it will take legislative policy, funders, government representatives, ministers to really take bold steps. Nursing needs to be at the table. We need to pull up that chair and have our voice in the room as well to make sure that these things happen on behalf. It's part of our moral code and ethical code to make sure that we are in the room and our voices are heard in these discussions. And I'll just conclude by saying, now is the time for change. Thank you so much for your attention today. I really appreciate it.